Welcome everyone to the Senior Living 411 series. Good evening. My name is Desiree King and I'm the founder of the Senior Living 411 company. What we do is we offer an affordable and comprehensive 240-point senior home safety assessment, whereby we will leave you a written safety survey summary and recommendations. We also offer a simple management service specifically designed for older adults wanting to age safely at home and families who may not be able to ensure the basic safety, security, and upkeep of an aging parent's home. So to help protect older adults from elder abuse and financial exploitation, we also maintain a vetted network of screened craftsmen to perform any necessary interior or exterior repairs. Our mission is also to provide education and resources designed to help people live empowered lives and make informed decisions. And out of this mission was born the Senior Living 411 series. The 411, it's what Ontario seniors and their adult children want concerning aging in place, in-home healthcare options, retirement planning, healthcare, and much more. These topics, along with others, are presented in the Senior Living 411 series as a 30 to 60-minute monthly educational seminars on Zoom and Facebook. Adults 55 plus, seniors, and caregivers are invited to attend the free Senior Living 411 series seminars to learn the actual facts about issues relating to aging. This series of candid conversations and expert panel discussions about the unique and often complex issues facing families are moderated by myself, Desiree King, or by my husband, Alpha King. These discussions allow families to get to know the person behind the profession, thereby creating a safe space to ask questions, learn, and ultimately form proactive relationships so that when a situation arises, you can reach out to someone you can trust. Today's topic is the 411 on cognitive skills and the aging brain. Joining me, I have Miss Carolyn Tinglin. Carolyn, welcome to the show.
Hello, and thank you so much for having me. This is awesome.
Great. So before we jump into the conversation, I'm going to tell you a little bit about Carolyn. Carolyn is a registered nurse with a master's degree in rehabilitation science and education. In her 20-year nursing career, she has worked in acute care, community care, mental health, and seniors care. In 2007, Carolyn decided to follow her passion for seniors care by working as director of nursing in long-term care. Years later, she took her passion for seniors care to post-secondary education and became an instructor and assistant professor of nursing. In an effort to build on her teaching career, she's currently working on her PhD in education at Simon Fraser University. Currently, Carolyn works as a gerontologist, specializing in holistic approaches to seniors' health. That includes physical, emotional, and cognitive needs, engaging seniors in cognitive stimulation therapies, and providing education sessions to families and community-based care agencies. Carolyn, once again, welcome. I'm so much looking forward to having this discussion with you.
Thank you so much. I really appreciate it. Thank you. Thanks for having
Great.
me.
All right, so Carolyn, I'm going to jump into my first question that I ask all our guests. What is your story? How did you get into nursing?
Well, I got into nursing because my late mom and dad, basically it was mostly my late mom though. She was, kind of pushing me in the direction of healthcare, and she'd heard great things about nursing and how flexible it is, and you can travel, and so she was really excited. I actually came out of school, out of Ryerson, and was in their theater arts program. So this was a 180-degree turn for me. And
Mm,
yeah, so just based on her, you know, encouraging me, and my dad encouraging me as well, I said, okay, well, I'll try it. Yeah.
wow, that's ironic. My mother as well, she's a nurse that specializes in gerontology and she attended Ryerson as well.
Mm.
She too had a push for me to go into nursing like her, and I pushed back and ended up in IT. But somehow my career led me straight back to where she wanted me to be. So it's funny how
Yeah,
our paths
there you
lead
go.
us to where we are. So Carolyn, what really motivates you? What's your biggest motivator in your career?
Um, I always tell folks that When I started as a nurse, I spent most of my first year at Sunnybrook Hospital. I did actually my internship there, my last clinical rotations there in acute care. And then my second year, I was like, oh, I want to branch out. I want to do something else. I actually saw an old schoolmate of mine who was working at North York General,
Okay.
and I was working with an agency. So I ran into her on her unit, and it was a telemetry unit, and I didn't know how to read telemetry strips. And that really bothered me.
Hmm.
So yeah, so I was like, oh my gosh, I feel like less of a nurse or something. Like it is a specialized skill, but I just personally felt like, oh my gosh, why don't I have this skill? So I actually went to the States and worked in the States, and I worked in acute care, and a friend at work said, oh, why don't you try working with this agency? They send you all over the place to long-term care homes and stuff, and it's kind of fun. So I tried it, and I fell in love. So I loved the fact that I could work 1 week, go to the nursing home or go to the long-term care home, and then come back 3 weeks later, and the same people were there, because that's so
Wow.
different from acute care, where it's you don't get to establish those relationships. So that's what really motivates me, is like having and connecting and creating those personal relationships, which as a nurse you kind of have to do that quickly, but in long-term care you get to take your time and you get to listen to seniors, and that I was hooked. I was hooked.
Wow. Wow. So you kind of segued into my next question of how did you identify your area of specialty? So it was something that you kind of discovered accidentally, then I think it was safe to say, and you discovered you loved it.
I did. I had no idea that I would love it, but just those connections and the conversations and having the privilege to care for people who, are in that position, and they are in a care home, that just made me feel really good. I mean, I will say there's a bit of a stigma, or there kind of still is, nursing students always want to go into acute care. That's fancy, it's flashy. And so the whole idea of working with older adults or working in long-term care or even home care is not as appealing to students. And so I've kind of turned that around. And when I was teaching, I made sure that I let students know it's a wonderful area to get in. You really have to use all of your skills, especially your communication skills, your assessment skills, because you're not given a lot of tools that you would be given if you were in acute care.
Right, right. Okay.
Yeah.
Well, what, just so our audience is clear, what exactly is geriatric nursing and what are the duties of a geriatric nurse?
So a geriatric nurse specializes in older adult health. So there are a variety of positions or roles that you can play as a nurse in a geriatric setting. So the story that I told you, I was a bedside nurse working in long-term care. Sometimes I would work in assisted living as well, which was really nice. But those are kind of the settings: long-term care, home care, assisted living, even independent living, depending on the province that you're in, because the regulations are different from province to province. And obviously in the States, they're different from state to state. So they may not require a nurse in independent living, but with assisted living and long-term care, or home care, it's just really specializing in taking care of, assessing the needs of older adults.
Right. And what are some of the most common geriatric disorders that you've encountered with older clients?
Oh, wow. I don't know. Well, okay, so common ones: memory issues, so mild cognitive impairment, a variety of dementia. So it could be Parkinson's, Alzheimer's, that's pretty common. Um, Folks who have physical challenges, so they may be at risk for fall, so they fall a lot. They've got a history of broken bones or broken hips. They may have gone from being actively mobile and walking around to mobilizing in a wheelchair. That's fairly common.
Hmm.
Heart disease, unfortunately, heart disease is quite common as well. So you're looking at folks who, especially in a long-term care setting, are unable um, to manage their health independently, as
Hmm.
opposed to in home care, where people are managing their health with a little bit of help. But
Yeah,
those conditions and diseases are fairly common.
exactly. And what age do you become geriatric? Is there an age that is a benchmark for that, or is it
Oh,
when the skills that your ability declines? How do you define geriatric?
it's a combination of both. So depending on the theorist that you follow, geriatric could mean 65,
Okay.
and that's it. Geriatric could mean 65 and over 65, 65 and older, and having challenges, significant challenges with your health. Some people define geriatric as the frail elderly as well. So it depends on the theorist, or the environment that you're working in. But generally speaking, you're an older adult.
Hmm.
Personally, I say 75 and up, 70 to 75 and up. And yeah, and you've got multiple either conditions, or you have multiple challenges that you're managing, or you're getting assistance to manage.
Right, right. Makes
Yeah.
sense. And I know that what is the geriatric assessment, and who needs one?
There's more than one geriatric assessment. The most common one is the mini mental status exam, or we call it the MMSE. And that's just a general, it's very old. So it's been around like decades. It's been around for a long time. And it's just a general appraisal of an individual who may be having changes happening. So the family member has noticed, oh wow, so and so forgot, my mom forgot her keys, and she keeps forgetting her keys, or mom keeps repeating the same stories to me, or I was having a conversation with her last week and she didn't remember that conversation. So it's a more global assessment of someone's cognition, their ability to think, to make judgments, to communicate. The MOCA, which is another assessment that I use, is also similar in that it does assess a person's abilities, but it's much more specific, and it's typically used if cognitive impairment has already been established. So the MMSE this is kind of new to us. We see that something's happening with mom, but we're not sure. We can't put our finger on it, but something's going on. And the MOCA is, well, we do know that she's got cognitive impairment. Maybe we want to see just how far that's going, or how well that's going.
Right. So for
So
family,
people who,
go ahead.
go ahead.
So
I was
I
going to
was
say,
about to say, yeah.
for people who are living at home independently, people who are in long-term care, it really, the setting isn't really what might trigger that type of assessment. Someone who needs that assessment is someone who their behaviors are changing, their thinking is changing, and so whoever their loved one is or care provider, they're concerned about those changes.
Mm-hmm, mm-hmm. So someone who, what would be the first step? I'm living, my mother is living on her own independently, but I noticed the house is not as tidy as it used to be. I check maybe her blister pack, and I see that she's not really staying on track with the pills maybe, or she's being a little bit repetitive or forgetful. Is that a trigger then that I should go in, would I speak with my doctor, or what would be the steps that I would take?
Yeah, so typically what's recommended is, that mom gets taken to the doctor. With those specific symptoms or behaviors, there are a variety of things that could be going on. Mom could have a urinary tract infection, and that's what's causing these changes. So it would be really important to get mom to the doctor and see what's happening, and then take it from there. So the doctor will more than likely, GPs do, they don't, maybe not all GPs like to, but GPs do MMSEs. They're more than, capable of completing that type of assessment. And sometimes it's just like a general question and answer. How are you feeling? How are you doing? Are you noticing any changes? Are you noticing that you're not remembering things? Are you having trouble with, cooking yourself a meal? Or tell me how you would prepare a meal in the morning, type of thing. So it could be just those general questions, again, to get a kind of global idea or holistic idea of how that person is doing, or how mom is doing. And then from there, the doctor has a couple of choices. A doctor can make a referral to a geriatrician or to a gerontologist to do more specialized testing, and to also follow that person if they're living at home alone, to just keep up with that individual, to support them, mostly with their medical needs. the doctor could say, well, I'm gonna, I think it's important that we run some blood tests. So let's get some blood tests taken and see what's happening. Mom hasn't had a blood test in a while, or maybe we should get an MRI or a CT done of the head, or
Right.
an ECG done, that kind of thing. So, but the first step really is to just kind of get to the family doctor, get to the GP, and take it from there, for sure.
So just kind of segueing off that, I know we had a discussion before where we were looking for a geriatrician, and they're very compared to the population in Ontario, the number of geriatricians available, there are not many. What is the benefit of an older person having a geriatrician as opposed to a family doctor, and when should they seek out a geriatrician to help?
So a family doctor obviously doesn't specialize in older adult health, whereas a geriatrician does. So they're very familiar with disease processes, conditions, lab tests that need to be done. They're very good at putting the medical pieces together and getting that picture that you need. I find also that geriatricians have more time to spend with clients. So that's the other piece as well. They very much are holistic in their approach. So it's not so much a 5-minute conversation, or, kind of in and out. It's very much, you're coming to manage the care. So I will say that even when a geriatrician is involved, the GP is still kind of helping to lead the team and lead what needs to be done. The geriatricians typically will act as consultants. So they'll make recommendations, they'll see the client, they'll make recommendations, and then they'll pass it along to the GP to make sure they're getting done.
Okay, so that gives a little bit of clarity on that. And what would you say is the most challenging part of diagnosing a patient's condition? Aside from sometimes I know, things are happening and our parents are confused themselves and they don't want to lose that independence. So they may withhold information. So what's the most challenging part of diagnosing a patient's condition?
So as an RN, I can make nursing diagnoses. So I don't
Okay.
make medical diagnoses. So from that perspective, I can certainly speak to that. So what you mentioned is very true. So when I do my assessments, quite often, more often than I like to admit, um, clients will say, well, I want to get everything right. I want to get all the answers right. And then I have to remind them, there are no right or wrong answers. Just go ahead and tell me whatever you'd like. And you know what? You also have the right to not tell me what you don't want to. So I go into that assessment knowing that there is that chance that they may not tell me everything that's happening, or they may not answer my questions fully, but that's their right to do so. So, I work with what I have, but I try to make people feel as comfortable as I can so that they'll share with me as much as they are wanting to, so that I can help them. But I think that is one of the challenges, of course. And if things are happening with the client that are somewhat acute, so things like pain, things like very new onset confusion. Those are things that are very more challenging to tease out before you get to a diagnosis. So there's more questions to ask, more observations to make before you can figure out like what is happening. And both, unfortunately, pain and having an infection can impact someone's cognitive abilities and their abilities to think and be logical. So there's that to think of as well.
Mhm. And how do you deal with the more difficult patients who aren't really giving you much to work on aside from the medical part of it? How do you deal with that? The,
Um, I even when I was in long-term care, I would tell staff difficult patients or residents are just VIPs. They need more attention. They need more time. So in my experience, those have been two really key things. So it's a matter of giving them the attention, figuring out what it is they are willing to talk about and want and comfortable with, and giving them the time to express themselves. So again, my assessments, in terms of completing the assessment, may only take 45 minutes, but it's the additional information that people are providing that
hmm,
makes it, end up being an hour or an hour and a half. But I don't consider anyone to be difficult. I literally I accept and I encourage people to exercise their right to tell me or not tell me. And
Right.
they're, they are the leaders in charge of their health. So they have a right to make those decisions. And, there's nothing that I can do about that.
Yeah, yeah, exactly. And how is cognitive function affected by aging? Like, what are some ways that it's affected?
So with cognitive function, so typical aging, right? Like we get up there and there are some typical changes. So you've got sensory changes, changes in hearing, changes in sight that can affect your cognition.
Right.
You have medications that can also contribute to someone's ability to think clearly. That can either be acute or something that's chronic. Um, from a biological perspective, as we age, we do lose a certain amount of gray matter over time. We can also uh, have changes in the amount of buildup that's also in our brains as well. They call them plaques. Again, depending on what model you follow, but biologically, those plaques can get in the way of neurons communicating with each other, and so that can cause serious issues with memories, with judgment. So, from a home standpoint, that's always going to be a point of concern, right? Can someone function um, fairly well at home on their own? Do they make good judgments about how long they leave something on the stove? Do they turn off the stove? Do they understand um, uh, how much time they need to get prepared for an appointment? Are they taking care of their personal hygiene? So that's kind of, I don't want people to think that, oh, okay, because you're aging and these things are happening, you're going to have problems in these areas. That's not necessarily the case. Each individual is very different. But as we age, we do have these certain areas physiologically that are changing. Yeah.
So is it a good idea then for family members, once they notice things starting to change, to kind of like journal it? So then they can show like a timeline and what changes they've noticed, just so you have more information to build upon? Would that be something
That's a
helpful?
great idea. That's a great idea. Also, sometimes people will videotape, right? So they'll bring the the videotape, the recording of mom or dad to show the family physician, and that's very helpful as well. But journaling is a great idea. Just noting the changes. Sometimes I've found that client family members will literally use a simple calendar. So that on the calendar on the wall, they'll just write, mom forgot blah 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 blah. Something
Yeah,
simple like that. So that's a great idea. Yeah.
right, right. And what is the difference between normal cognitive and abnormal? Like, how do you really, okay, this is quote unquote normal, and this is when it's crossing the line into abnormal.
Yeah. So there are so the subtle differences are really in severity. So again, you're looking at issues around memory, around repeating. Some family members may report that their loved one is repeating things a lot and not remembering that they're repeating. From a functional standpoint, things that are typically not or typically haven't been challenging to do. So, for example, if your mother typically washes up the dishes, once every couple of days and doesn't really have any challenges with that, but this particular week you come to visit mom and it's been 5 days and the dishes haven't been washed, that's kind of the difference. So it's the severity of these changes.
Mhm.
Occasional forgetfulness, people freak out. It's like, oh my gosh, this is the beginning. No, occasional forgetfulness is part of typical aging. And I will say, the busier that you are, the more responsibilities that you have, the higher your risk that certain things are just going to be forgotten. So it's not a reason to panic. But if forgetfulness becomes persistent, that's a different story. If what is being forgotten is fairly important, that's fairly significant. That's a big difference. Occasional disorientation. So if this happens to me every once in a while, This happens to me every once in a while, but you go to the grocery store and you come out and you have a general sense of where your car is, but maybe you forgot the stall, right? Like that's typical aging versus no clue whatsoever, no clue where the car is. Maybe the person is even confused about the color of the car. So it's the severity of it.
Mm,
Word finding, sometimes I know that people will trip up on words, or they'll forget a word and it's right on the tip of your tongue. That happens occasionally. That's typical aging versus like true word finding challenges. They're not able to come up with fairly simple words. Sentences are difficult and becoming more laborious to form.
right, right. And what are the warning signs now of dementia, or one of the dementias that are happening, Alzheimer's? What are the warning signs that it may be something more?
Serious is happening. So typically, we talk about cognitive impairment, which are those mild, happening every once in a while type of thing, but it's not impacting your function. It's not impacting your ability to do the usual pleasurable things that you do. Um, and then there's mild cognitive impairment, which is more, the cognitive changes are much more noticeable. Um, maybe they're concerning to family members. Again, the forgetfulness, the repeating, it's quite persistent and it's becoming that person's norm. Maybe more than one of the cognitive domains are being affected. So it could be sensory, it could be thinking, it could be judgment, but there are a couple of things that are definitely off. So in terms of examples, and again, I don't want people to
Yeah.
to panic. Um, but early onset dementia, we're talking about issues about judgment, making poor choices. So that sometimes for some families, that's like a key. They know their parents so well that they know, okay, this is not mom or dad. Mom or dad would never choose to do X, Y, and Z.
Right.
That can be an early indicator. Making poor choices. Maybe it could be something as simple as you notice for the next week that mom or dad are putting on their clothes and their clothes are either inside out, the buttons are not done up in order, that kind of thing. And when mom or dad, they know how to dress themselves. So those are kind of key signs. In terms of being around the home, maybe you're noticing that mom or dad are kind of couch surfing. So, sorry, we call couch surfing when you use your furniture to kind of help keep you stable or kind of help you to judge distances. That can be definitely an early sign that they're having trouble judging distances around very familiar objects in the house. Um, Maybe they're not able to find items. And when I say that, it's not like, oh, okay, I forgot where I put my keys and now I found where
Yeah.
they are, but significant things like a purse or large objects or something that they usually have with them has gone missing. With that being said as well, if you notice that mom or dad are now, you know, I don't want to say creating stories, but they are divulging stories of people taking things. That can also be, you know, that's a change definitely in their thinking that you should be concerned about.
Mhm, mhm, yeah. And can is there a way to improve cognitive ability? Foods you eat or exercises. I know they say like Sudoku and word puzzles, games that stimulate the brain.
Yeah.
Yeah, what are some ways to improve the cognitive ability?
So the general rule is if it's good for your body, it's good for your brain. So that goes for diet, that goes for exercise, that goes for stress, that goes for stimulation, that goes for socializing. So those key things you need to continue. It's about not slowing down. It's about continuing to um, uh, feed your body, not just physically, but also spiritually and mentally and emotionally as you're getting older. So exercise is extremely important. There are numerous studies that show how exercise can help to improve cognition along with other things. So not by itself. Social interaction, believe it or not, having a conversation with your friend or your neighbor or your cousins forces your brain to utilize certain processes and to go through certain processes. So just having a conversation, engaging, knowing when to not speak, knowing when to interrupt, knowing how to, put your face or express yourself. Those are all things that we kind of take for granted, but they're very important in terms of our brain's function. So the stress, stress is bad all the way around, right? So it causes heart disease. It can, change the cellular structure of the organs in your body. So you want to make sure that you're managing stress really well. If you do happen to have chronic conditions, make sure that they are well managed. So if you have diabetes, and diabetes is a biggie, you want to make sure that you are taking care of your diabetes, you're managing your diabetes well, you're taking your medications in the way that you're supposed to. Those are all very important things. So continue to feed your body, not just physically, but eat the right foods, exercise, fill yourself spiritually and emotionally, and make sure that you're staying social, that you're continuing to connect with people.
Social interaction,
The
definitely.
games are good too.
Yeah,
Don't get me wrong, the games are good too, but that's
yeah,
not the fix. That's not really the fix. It's these other
right.
things that contribute and work together. And that's something that, that we do is help people to figure out for them specifically, what are some of the exercises, what are some of the activities that are going to help to keep them going, keep their brain going. Yeah.
Right, right. We do have some questions coming in, but I'll get to them in 1 minute. A thought that came across my mind is the social interaction part now is even more so affected with COVID and having to be isolated. What are some of the scenarios you're running into, and what are some of the coping strategies during a time like this for seniors, especially?
It's really challenging. So not every senior has a very involved child, family member, friend, or neighbor.
Mm-hmm.
For those seniors, we've definitely seen cognitive decline. We've definitely seen incidences where they're not eating as they should be, so they've stopped eating. They're definitely depressed, right,
Yeah.
because of the social isolation. And it's a matter of coordinating community supports for people who don't have family. They don't have any other supports. For people who do have supports, it's a little bit easier. We help families to figure out how they can support their elderly loved ones. So what can they do? Either rotating schedules, zooming with mom or dad, a phone call even. So even that phone call makes a big difference. Can they do WhatsApp? Are there activities, like sometimes we'll encourage family members to drop off activity boxes. So they should be meaningful. So they're not just any old, just bring a Monopoly or something,
Yeah.
bring a Monopoly game and drop it off to mom type of thing. But they're very carefully thought out and meaningful boxes. And the elderly loved one kind of looks forward to those being dropped off. And so there's that way of communicating. Letters, believe it or not, old school. So if the elderly person is not severely challenged with like sight and vision issues, then dropping off letters, that's also a form of communication. But it's looking at all the different ways to connect with that elderly loved one. Some people are not tech savvy, so you can't do the video chatting. It's just not an option. So we have to think of other creative ways that we can keep them connected.
Right. Wow. Okay, so I have a few questions. First one is, do any cognitive abilities improve with aging?
Not a lot of them.
Okay.
But then again, that's the whole idea, right? That don't stop doing those things. So believe it or not, the studies have shown that we gain wisdom. So as we age, we actually hold on to long-term lessons. We physiologically, I don't mean to get into a science class here, but dendrites actually increase their connections. Certain networks improve. And they're saying that kind of is the equivalent of wisdom, understanding more globally. understanding topics more globally than they did before. The other thing that they have said is that as we age, we actually have something called cognitive reserve. I don't know if anybody's heard of that. So basically, it means that when you were younger, the things that you did to gain understandings, the things that you did, at the age of 11, at the age of 17, some studies say as young as 11, and then other studies say as old as 20. So the education that you had during those points and up until those points are kept in reserve, believe it or not. So more studies are coming out that say, well, what you learned back then, you've got a certain amount of cognitive reserve that will help to help you to maintain what you have when you're older. Unfortunately, that really means that is socioeconomically stratified, right? So if you didn't finish high school, for example, or you didn't have opportunities for workshops or other types of education, that you're going to be at higher risk for having more cognitive issues and challenges when you're in your older age.
Mm-hmm. Wow, that's an interesting fact. Wow. Okay, so another question is, if someone's holding back during an assessment, does it hamper their score? Are you able to detect that they're holding back? And again, does it hamper their score?
So it depends on what the assessment is. Typically for an MMSE, if they're holding back, it doesn't make that much of a difference. But for other tests, it might. Sorry. Okay. Something in my throat.
Yeah, that's fine. Have some water there? Yeah.
Mm-hmm.
So I got mine here too.
Yeah, the MMSE is pretty straightforward. It's asking questions like, what day is it today? What year are we in? Can you add a couple of numbers forward? Can you count backwards? So it's like, if they choose not to answer them, it will affect their score. But there's no if they're holding back personal information on that type of assessment, it wouldn't make a difference.
Right. And that makes sense. That definitely makes sense. I have another question from Michelle. She wants to know, this is touching back again on dementia. Does forgetting words mean dementia?
Do not panic. Forgetting words. So we call that challenges with word finding, right? Finding the right word in that sentence, or, the right word to identify what it is that you want to say. Mm-hmm. Everything is very contextual. So if your elderly loved one persistently has problems, so it's not just a once in a while thing, but they persistently have challenges finding, word finding, that could be that they are having some cognitive challenges and cognitive impairment. But we can't just look at that alone. We'd have to look at the bigger picture, right? So, yeah.
Definitely. And another question I have from Avril is, can you explain some more about divulging people or taking things? If someone is saying, well, this person entered my room, they're taking things, or different stories like
that. Unfortunately is not uncommon.
Yeah.
So it depends what the disease process is that's either been identified or maybe not been identified. Parkinson's is a type of dementia, and quite commonly people with Parkinson's have psychoses, they have delusions. So that's what we would call a delusion, is that you believe that this is happening. You believe that your daughter took your purse, or that your son took off to Mexico for vacation, and that's why he's not here today. So unfortunately, delusions can be a result of a number of things. It could be a disease process going on, or it could be delirium. So delirium will cause someone to have delusions, and so it would be important to assess, how long has this been happening? Is it sudden? Are there other symptoms as well? Yeah, but that's not uncommon, but it is something that you should be concerned about.
Take note of. Okay. And can we just briefly touch on sundowning? When someone explain that to us. I won't go into my own
Yeah.
definition, but yeah.
Yeah, it's early in my career in the States, I would see it and I was told about sundowning and I was like, well, what do you mean? And then I would see it for myself. Um, so sundowning in general, what some researchers have noticed is that at a particular time, usually in the afternoon when the sun is going down, that an elderly person may have different behaviors. So they may have increased anxiety, they may have increased anger. They could also be the opposite and be very withdrawn, but their behavior is quite different. In many cases, I won't say most, but in many cases, the behaviors are typically combative. But again, these behaviors may be from anxiety, they may be from fear. Um, they no longer want to maybe cooperate with what it is that you're asking them to do, whether it's medications or to come for a walk or that kind of thing. But the distinct behaviors happen right when the sun is going down. Now, in long-term care, we attribute that to a change in routine because in long-term care and in assisted living, we have shifts, right? 7 to 3, 3 to 11, 11 to 7. So the fact that people will have that experience is not really that surprising because things are changing. Even though it's the same routine, that change is the same every day for that person who's experiencing sundowning. It's a change in their routine at that moment during that time, and that may trigger that person to behave in that way.
Mm-hmm. Wow, definitely. Just as we start wrapping up, what are some key skill sets of your career for anybody who's a younger person possibly considering entering this field? What are some key skill sets that you have to have?
Number one, you gotta love being with the elderly.
Yes.
You have to be very patient, right? And not in a rush. And unfortunately, with nursing, you are taught in school, it's very task focused, but you have to take a step back. So if you want to be in geriatric nursing, you need to be able to get your tasks done, but still see people, not as things to do things to, but as actual people with lives and with feelings. So you incorporate person-centered care so that yes, the tasks are getting done, but you're still connecting with that human being. You're still compassionate in terms of the privilege that you have to work with that person. You have to be able to multitask. Nursing is all about multitasking. You have to be able to prioritize. So you're going to have to know, well, should I be, this person's coding over here and this person, needs help getting toileted. What do I do? So you have to have that skill to be able to prioritize. Communication is extremely important. You're part of a team and nothing really gets done unless you're able to communicate even under stress, even when it's high stress, still be able to communicate respectfully and calmly with your team members and do the same with your residents as well. So yeah, those are pretty key skills.
Right. I have a comment, I guess. I can get you to comment on the comment. Laverne is saying,
Okay.
I have read an article some time ago that music therapy is very helpful for seniors in general. It has helped some Alzheimer's sufferers, enabling them to become more aware of their surroundings for a while. I've seen that myself in several videos I've watched where the person goes from non-communicative to hearing music and starting to sing and express themselves and reverting back to that time. What are your thoughts on that?
Oh, it's wonderful. I have a lot of respect for music therapists. Yeah, it is an absolute wonderful connection to have with a senior. And yeah, I've seen some of those videos myself. There's some place spiritually inside that is, you know, the medical experts don't have any answer for it, but there is something inside of us that really responds to music, and it could be a long term memory of music, or it could just be the art and the feeling that it provides to that individual, which kind of wakes them up, awakens them. But yeah, it's a beautiful thing to see. It's wonderful to see.
Definitely. And currently your title is a geriatric nurse clinician, correct?
Hmm.
So what does a day in your life look like? Do you actually, well, now we're in COVID, so do you do assessments more on Zoom, or what does a day in your life look like?
So I actually do assessments in person as well as online. Um, it's tricky. It's a lot of putting stuff on. Yeah, we definitely have to use COVID um, precautions, and so we kind of go above and beyond in terms of visits. I typically will schedule a visit, so I do a lot of talking on the phone, calling people, seeing how they're doing, especially because most of my clients have just been released from the hospital. They've just come out of the hospital. They live at home on their own. And as I said before, not everybody has family and neighbors and friends that will check in on them. So this is the check-in that I do with them. Sometimes I will get a referral from family members who are concerned about their loved one. And so again, I still make that phone call just to connect with that person initially. And then I set up a home visit, and the home visit, I typically do a few a day. And go into people's homes and use the COVID precautions and do my assessments, and then head back out. Yeah.
So I was going to ask you, and you kind of answered that slightly. What triggers someone's need to call you? Is it from a discharge planner, family member? What are the triggers that someone realizes, okay, I've got to call you in?
Yeah, so typically they are from family members, mostly from family members who are concerned about their loved one. They can't quite put their finger on it,
Mhm.
and they want to know and have some kind of qualitative and quantitative data to support what they know, what they've been thinking. Every once in a while, I do get calls from family physicians who would like someone. Maybe they can't. So the fact that you said there are hardly any geriatricians, their waiting list is redonkulous. So they have a very long waiting list. I've called like around 5 of them, and they're all like months long. So sometimes it's nice because people can change within that space of time, right? So someone who may be at risk can change in 2 to 3 months or 4 months or 5 months. So sometimes a doctor will call and say, okay, well, they are on the waiting list to see a geriatrician, but
Mhm.
I'd really like you to assess this person. I think, someone needs to come out and just check on them and see if there's any care coordination that needs to take place, type of thing. But typically it's family members. Yeah.
And just another question came to my mind because I've seen it. We all know the risk of falling for seniors and what it does to them physically, but mentally, the changes that I've seen that it's done to them cognitively. Can you kind of just take us into that? Is it a fear that's triggered? I've seen someone a good friend of mine who's, her aunt was in great condition. She's fallen a few times, but the last time she fell, she lives on her own and she didn't have a device. So she was left laying for about 18 hours until they found her. And now she's in long-term care because she just does not want
Deteriorated.
anymore. So what is the effect of falling really on someone's cognitive ability? What
You
happened?
you hit the nail on the head. Number one is fear. Number one is fear. So unfortunately, having a fall puts you at risk for falls in the future. But a big part of that is fear. And so um, some people would rather not ambulate than take the chance of ambulating. For some people, rehab. So if they got rehab in the hospital, rehab may not have gone that well, or the pain wasn't managed well. So that's another thing too, is we have we have a long way to go in terms of managing pain in elderly patients. That and depression, those are two key areas that I don't think we're doing as an industry, we do very well. Um, so yeah, it could be that the pain wasn't managed well. It could also be that, they would rather, sit around, maybe couch surf for some people, or just not ambulate at all, rather than get up. And of course, when you don't get up and get moving, you become more deconditioned, and that puts you at higher risk for falls as well. But in terms of their emotional state, it really is fear. And for some people, it can be quite traumatizing. I mean, if you're on the floor for 18, that's traumatizing. That is very traumatic. So, I mean, I'd be very very hesitant to ambulate as well, with the fear that that may happen again. That same situation could happen again, and I'd be in the same situation again. So the fear is not unjustified at all, but that's a big part of it. And in your mind, what some clients have told me is that they give up, right? So they see this particular fall as, okay, that really means I'm old, I'm not well, I can't do this anymore. I just can't. I can't do this anymore. Yeah.
The psychological damage is irreversible many times as well.
Yeah.
You know, Carolyn, this has been a great show with so much valuable information. Do you have any closing words for us on this topic? Some key nuggets that you'd like to leave with our viewers and our listeners? As you know, this is broadcasted as well in other places. So give us some key nuggets that you'd like.
Some nuggets. I would just say compassion is really important, right? So for family members or loved ones that you have that are maybe experiencing changes cognitively, compassion should be the first approach type of thing. So whether it's repeating a lot of things, whether you're concerned about mom or dad not understanding things, or their judgment is failing, to really keep that in mind, that it's scary for them as well. Some people, depending on where they are on their journey, may realize that these changes are happening. So if you can imagine how fearful they may be of these changes, not knowing why they're happening. The second thing is, call your doctor, call your GP. If you are, not sure what's happening, and you do have some concerns, call your GP. Call your GP. You can let your GP know, hey, I know of a geriatric nurse clinician, or I know of a gerontologist who could, probably spend some time with mom or dad. Whatever the case may be, get your loved one to the doctor so that at least, they can run blood tests, they can rule things out so that they know what's happening with mom or dad. I think those are two biggies. Safety is very big as well. And I know, Desiree, that's, the falls issue. I'm so glad that you have your company and that you're helping people with that. That can be life-changing. So again, if you're in doubt whether mom and dad are safe, if you feel like they're using, furniture to get around and they're couch surfing to ambulate, that's of concern. So again, you want to get that help as quickly as you can.
Yeah. So several different segments are different things you have to look at for the holistic approach in preventing something worse from happening.
Absolutely.
Exactly. So if any of our viewers wanted to contact you, how can they do so? Do you have a website, your email, your phone number? And we'll share it in the chat as well.
Yeah, our website is thrivehealthcanada.com. And it's Thrive Health and Wellness. That's our website. And I think we're thrivehealthcanada@gmail.com if you've got questions. But if you go to the website, kind of holds your hand through the website so that, you can look around. We also offer courses. So we offer education courses as well for family members. We also offer very specific and customized education for families as well. So if you're looking at trying to figure out how to work with mom now that these changes have taken place, it's really frustrating, we're not getting along, how do we do this? We can help with that as well. So I will put the website in the chat, but it's thrivehealthcanada.com.
Awesome. That is so amazing. Laverne says she wants to thank us both for this wonderful presentation, so much informative information. Thank you, Laverne. I'm glad that you've enjoyed it. And again, Carolyn, thank you so much. And if anyone does not have the information, feel free to reach out to me. I will definitely send you Carolyn's information as well. And our next show will be the 411 on insurance for seniors. We touched on this topic last November during Fall Prevention Month, and I felt the need to delve further into this topic. So join me on Sunday, March the 21st, as my special guest, Owen Roden, and I will discuss the 411 insurance for seniors. So I want to thank you again for joining us, and remember that all discussions can also be found on YouTube on the Senior Living 411 Inc. channel, or on the Senior Living 411 podcast. If you don't like to watch, you can listen. So please remember to like this broadcast, share this broadcast, or subscribe to this broadcast, and follow the Senior Living 411 Incorporated Facebook page, or request access to the Senior Living 411 series private Facebook group. With that being said, thank you once again. Thank you, Carolyn. And remember, one call could prevent a fall. Stay safe. And if you have any questions, you're in doubt, reach out to Carolyn. She has a wealth of information. We just touched on the surface today. So
Thank you
thank
so
you.
much. Thanks. This is wonderful. Thank you for having me.
Thank you.